Good day, everyone. We are thrilled you've joined us for today's Learning Live session, CTP Strategies for 2026, where clinical practice meets payment reality, sponsored by LifeNet Health Biologics. My name is Miranda Henry from Wound Care Today USA, and I'll be your host for today's live broadcast. Whether you're joining us on YouTube, Facebook, or LinkedIn, we welcome you. We're excited to connect with you in real time across multiple social media platforms. I have just a few quick notes as we get started here today. This session is being broadcast live and will also be available for on-demand viewing after today. We want this to be interactive, so don't be shy. Please drop your questions in the chat. Let us know where you're coming from. Let's get a conversation going there. Throughout the presentation, we want to hear from you. We'll be monitoring all the platforms and we'll address as many questions as possible during our Q&A segment. So again, keep those chats going. Don't forget to like, share, and engage with today's content. Help us spread this important education to your colleagues and your networks. And of course, if you have any technical difficulties, we suggest trying to refresh your browser or switching to a different platform where we're streaming. Now, before we begin, I have just a following important disclaimer to share with you. This webinar is presented for informational purposes only. The content is intended for healthcare professionals and is not a substitute for independent clinical judgment or institutional protocols. Participants should consult applicable clinical guidelines and facility policies when interpreting or implying information from this program. The views expressed are those of the presenters and do not necessarily reflect those of the organizers or any sponsors. For a little bit of background on today's topic, the 2026 Medicare Physician Fee Schedule brings major payment changes for cellular and tissue-based products in wound care. Understanding these changes is essential for both clinical and financial success. Today's Learning Live will explore what these payment changes mean for your practice. You'll learn how to review your CTP formulary strategically, see real-world wound cases, and understand the documentation supports medical necessity. Most importantly, you'll leave with strategies you can implement immediately. And now I would love to introduce you to today's exceptional speakers. I have here with me today Kathleen Schaum, who is the founder and president of Kathleen D. Schaum and Associates, where she has established herself as one of the nation's leading experts in healthcare reimbursement. Kathleen's deep understanding of Medicare policy and payment structures makes her uniquely qualified to help us navigate the 2026 Medicare Physician Fee Schedule changes and their implications for CTP services. Also with us today, we have Dr. Alton Johnson, who serves as the Assistant Professor of Orthopedic Surgery at the University of Michigan Medical School. Dr. Johnson brings extensive clinical expertise in diabetic foot ulcer management and will share real-world case examples featuring 2 CTPs, demonstrating practical clinical decision-making at the bedside. Together, they'll provide both the regulatory framework and the clinical application you need to succeed under the new payment models. So we are going to kick off today's Learning Live with Kathleen Schaum. So Kathleen, the floor is yours.
Everyone, I am so thrilled that you are here and reminding you that the only rule we can talk about today is the Medicare Physician Fee Schedule final rule, because that's the one that has been released. And as you know, that was the Halloween surprise. We are still waiting for the OPPS final rule. And when that comes out, then we will have more to say about that. But for our disclaimer today, for reimbursement, we have to remember that the information that we're giving you about Medicare payment is actually provided as a courtesy. It doesn't constitute a guarantee or warranty that you'll actually be paid or that you'll get to keep your money after an audit. And the Medicare payment information was current as of November 17th, 2025. But like all things Medicare, it is subject to change, so always pay attention. And then wound and ulcer management professionals should obtain the current payment system information from the correct payer. So if you don't happen to be taking care of a Medicare patient, you need to check about the Medicare Advantage or the commercial payer, Medicaid, etc. And with that, reminding you that we use the term current procedural terminology, or the acronym CPT, and that is a registered trademark of the American Medical Association. Now, the registrants were so kind because yesterday we sent out 3 polling questions to the people who registered, because we wanted to get a pulse of what have you done to prepare for this final rule. And so we're going to actually share with you what the respondents said about these 3 polling questions. So the first one was, in light of the 2026 Medicare Physician Fee Schedule, which is better known as MPFS, did you delete or add any cellular and or tissue-based products for skin wounds to your formulary? And so let's take a look. I was a little bit surprised by the answer, and that was that 57% of the respondents said they had already made some changes, but 42% have not, almost 43%. And so that's a little nerve-wracking to me. And I think when Dr. Johnson talks to you about the time, how long it takes to change things in his health system, you will see why this concerns me, because this final rule goes into effect on January 1. So if you haven't clearly looked to be sure that the items that are on your formulary are going to align with this payment schedule, I suggest that you do that. The next question was, in light of the 2026 MPFS final rule, have you changed the size of the CTPs that you purchase? Because there are some things that make us know that we have to be a lot more size specific to the size of the wound. Well, wait till you see this answer. 28% of the people said they had made changes in their size, but 71% say no, they haven't. Now, maybe that's good news, because maybe everybody already is using wound-specific sizes. But if we're not using wound-specific sizes, we really have a lot of work to do to add some additional sizes to our formulary to more align with the size of the ulcer. And the third question was, in light of the 2026 MPFS final rule, have you evaluated the affordability of each CTP on the formulary? And this surprised me a little, because I thought that would be the first thing that everybody might do after that fee schedule came out. And guess what? 57% said, yes, we have evaluated the affordability. And the other 40, almost 43% said, no, we haven't done that yet. So we have quite a lot of work to do. And I am glad that I asked these polling questions, because it allowed me to speak to you honestly about the fact that this is a final rule and we have to be ready. So let me just remind you of the key points that we have to talk about for the payment for the physicians and other qualified healthcare professionals. And as you know, the acronym for qualified healthcare professionals is QHP. Now, always in the past, all right, for years, physicians and QHPs always receive a higher payment rate when they apply CTPs in a non-facility, such as in their office or patients' homes. And that's been how it has been for years. All right. And then they get a lower payment rate when they apply the CTPs in facilities, such as in a hospital-owned outpatient wound and ulcer management provider-based department. So that did not change. However, you also know that there is a conversion factor that converts the relative value units of the application codes to money. And in this year, if you are a physician or QHP who participates in an alternative payment model, you will receive a higher conversion factor, which is 3.77%. And those who do not participate in an alternative payment model receive a conversion factor of 3.26%. I think, if anything, that tells you is that Medicare is trying to get more and more physicians to align into an alternative payment model. So those are sort of the two major rules we have for the application, which is the work. All right, so how does that turn into money for 2026? I did this based on the physicians and the QHPs who are not participating in the alternative payment model. So if you look at column 2, that is the application rates for the physicians in 2025. And the top 4 were for the applications on the legs, and the bottom 4 were the applications on the feet and other small anatomic locations. So let's just look for a moment at 15271 and just use that as an example because they all kind of align the same. 15271, which is the application of a CTP to an ulcer that is 25 square centimeters or less. In 2025, if we did that in our office or a patient's home, the allowable rate, the national average, was 148.47. And then you look in column 4, you will see that for 2026, that went up. And now then, look at what happens if we did the work in a facility. So look at column 3 for 15271. In 2025, the physician was paid $81.51, and that makes sense because the physician didn't have to buy the product. The facility purchased the product. All right. And he didn't have to do all the support with the staff, etc. He had the support from the provider-based department. So he had 81.51, but then notice in the last column, the 5th column, you will see that the rates went down. And in that case, it went from 81.51 to $75 and change. And if you read the entire final rule this year, you will see that Medicare has bumped up the rates for physicians who do the work in their offices and has reduced the rates, not just for this procedure, but for most all, and reduced the rates for if you do the work in a facility. So that kind of gives you a lay of the land of how that turns out. Now, keep in mind, these are national average allowable rates. So your particular state, on your particular area, you could possibly be getting a little more than this or a little less than this. All right, so now that we've talked about the application, the work to apply the CTPs, let's talk about the payment for the product. And that was the big question for the year. So we have some important things that stayed the same and some things that have changed. So when you report a CTP on your claim form, you still must use the correct A code or Q code for the product. So you must always report the right code that aligns with the brand, and they are assigned by brand. Now, we've also always been paid, the physicians and QHPs, when they buy the product, they have always been paid separately for the application and then the product. That actually stays the same. However, in the past, there were separate rates for different products. This year, we now have the same rate for all brands of CTPs. And that national average allowable rate is $127.28 per square centimeter. So when I tell you, did you check to be sure the affordability of the products on your formulary? This is the reason why, because this is the rate, all right? And it doesn't matter what the brand is. This is the rate you will get when you purchase these products in your office, or if you purchase them for a patient at home, etc. Now, there's a few exceptions to this. Number one is if the CTP has received their FDA approval through the Biologic License Application Pathway, BLA, they will still be paid the average sales price plus 6%. But do not think, oh, yep, because there's a lot of those products. Actually, there's not very many at all. All right, so that really doesn't apply much to the products that exist today. Doesn't mean there won't be some in the future, but today there's not many. The other exception is in the past, we were never covered for any product that was not a sheet. All right, and Medicare would not pay separately for something that was not a sheet. So if it was a sprinkle, a gel, a powder, an injectable, we would not get paid separately for that. Now, this year, they're saying, yes, if the payer says it's covered, so if it has the evidence, we would pay for the non-sheet products, but not at $127.28. Instead, it will be up to each Medicare administrative contractor how much they would pay if they cover those types of products. And those products all have codes. And if there happens to come some new to the market that don't yet have a code, then indeed you will use the code A4100 to represent that. And they did change the descriptor of that code, which is why I wrote it out. The descriptor now is a non-sheet form skin substitute, FDA cleared as a device, not otherwise specified. And then in parentheses, list in addition to the primary procedure. Now, there is the one question we all have, because we know that the sheet products, when you're talking about from AMA coding for the application codes, we know in the AMA CPT book, it clearly says you cannot use the application codes for applying anything unless it's a sheet. But notice this doesn't really say the application codes. It says the primary procedure. Now, we're going to still clarify this, but what it says to me is whatever the physician did that day, all right, he would, if the MAC believes this is covered and has the evidence, then they would just bill it in addition to whatever they billed that day. So let's say it was debridement, then they would bill this, the code for the non-sheet products on that day. So that's That's all the information we have. So we're going to definitely check that, but we're pretty sure that's what it means. Now, I've talked a lot here about coding and payment, but I want to remind you of something, that the existence of a code and the payment rate for a service, procedure, or product does not mean it is covered by the payer. So just because I have that sentence up there, that second bullet point that says CMS will pay $127.28 for any brand, yes, if it is covered. All right, that is the caveat that we all have to be very aware of. Now, as we spoke to Dr. Johnson, I was very interested to know what all he had to do to get prepared for this. And he's known, we've all known that there's going to be a change in the payment system, et cetera. And so I would like to ask him a few questions and see what he can tell us about how he got ready for this particular new final payment rule. So, Dr. Johnson, my first question to you is, did the CTPs on your formulary have published evidence? And are their purchase price below $127.28? And do you know?
Yeah, so of course a Kathleen question is always twofold. So yeah, that's a two for a price of one. So yes, technically all the CTPs on the formulary at our institution do have published evidence, which we combed through over the when we were MP was I think it was going to be in the spring. Am I correct? For the LCD changes. So we kind of had prepared for the LCD itself. So we had gotten the published evidence for that. As far as the pricing, right now we're currently undergoing the renegotiation of this. Where some of our products are pretty close. I would say if you had to do a standard deviation to the 127, most of them are either probably maybe $20 to $30 above that. So I think the renegotiation of the contract should be fine for most of the ones that had made the cut for the published evidence. But yeah, we did have to delete some out because they did not have published evidence for the coverage for CTP. And then, of course, right now, I mean, like I said, it was the Halloween surprise. So we immediately started because Halloween was on a Friday, we immediately started that Monday with contract renegotiations to prepare for this 2026 implementation.
Okay, and so you hope and you hopefully will be able to get that done, especially
Yeah,
since you started right away.
yeah. So we already, because we already knew what products that we are going to use, our products that we have been using. So I think just more so contractual situation, which I don't think will take nearly as long as going through the published evidence, the CTPs that we wanted, and the price, and then now you're going through a price situation, which is much different. It should be, I think it'll be more expeditiously executed versus the other, situation.
The
Figure
evidence
out
effort was a
yeah,
bigger
exactly. Yeah,
lift,
figure it
right?
out. Yeah, because and it goes back to that disclaimer of just because they will pay it, it may not be covered, and that goes the same thing for other products. So just because X product may be covered doesn't mean Y product is going to be covered. So you have to be very careful of that for your patients.
Perfect. So let me ask you the next question. Is now this CTP formulary that you have, does it include a variety of sizes to accommodate all the ulcer sizes, or did you have to adjust that?
Yeah, we have to adjust that as well. So luckily, like you said, we just from a standard of care practice, we always try to make sure that the actual wound that you're treating and the product that you're applying or the CTP that you're applying was the appropriate size, not going too big, not going too small. Obviously, trying to find the right fit. So we had also went through that and pretty much added on the other sizes that we needed when we went through the evidence published evidence for these products. So not even anticipating, we all knew that there will be a new, a nominal or numerical value or associated with the CTPs. Not knowing the exact number, I wasn't too worried about it. So that's kind of how it goes. So we asked for either large. Some of them we asked for larger sizes because anticipating it, and then some of them we had to add some smaller sizes as well for the anticipation. But we do have to answer the question, we do have a variety of sizes for all the CTPs that are on formulary.
Right, and that's a good thing to do because you have to get them onto your charge master and
Oh,
your
that
able.
could take, yeah, that took 60 days or longer, probably longer than that, to be honest. Yeah, you have to, yeah. So even if you get a product approved, even with the pricing, doesn't mean that you can go and charge for it the next day. At least not in a big system like ours. That takes a lot of coding, and then you go, like I said, going through the charge master, going through your EMR, making sure it actually lines up, make sure it's appropriate. That alone, from the IT standpoint, a regulatory standpoint, rev cycle standpoint, can take 60 days. So even if I just said I wanted to use X product today, and it was already at the 127, doesn't mean it's going to happen tomorrow. It could be until next year before I could actually do it, January, something like that.
Right. And that's why I'm encouraging everybody to get started with this process.
Yeah, which is perfect timing of this webinar.
Right. So, do you use any CTPs that are gels, powders, liquids, or injectables?
Yes, I use some that are considered. I guess you would consider it either a ointment, and also use the powders. So they're not the ointment was not necessarily called a CTP, so it is in that carve out none sheet product. So it doesn't necessarily go to the 127. But yeah, the powder products, you're right. You have to go through the payer, and most of the powder products we use in surgical setting, which is a whole other caveat,
Mhm.
right?
Okay, perfect. So, as you were talking about the charge master, have you verified now that when you made your formulary changes that you're reporting the correct codes and the correct charges for the application of the products as well as for the products themselves?
Correct. Yes, making sure you have the right quantities and making sure you have the appropriate. So if it's the foot, make sure it's the foot versus the leg, and things like that. Yes, correct. That all goes into the figuring out what rev cycle and IT and the charge master are, as well, when you assign these new CTPs or renegotiate these CTPs. Yeah, that's all been verified. That too takes time. So
Perfect. And so here's the $100 million question. All right. Is Did you have to refine your documentation to support these CTPs? And
100%.
through three kind of thought patterns. One, your standard of care, having excellent standard of care and documenting patient compliance. Two, the medical necessity for the CTP. And three, the medical necessity for the specific brand of the CTP. So talk to us about that because before you answer, I will just tell the audience that in my consulting work, if I could only fix the documentation, I just feel very, very sure I can't keep an audit from happening, but I could certainly keep people from failing their audits if their documentation better represented them. So, Dr. Johnson, talk to us about this.
Yeah, so we have just luckily for me, I have internal audits that I have to answer to. I think it's maybe every quarter I get internally audited, and they will come in. Basically, we have a mini Kathleen that comes in and looking for if this, excellent standard of care is documented, including patient compliance, the medical necessity of the CTP, and then, of course, like you said, is the medical necessity for the specific CTP that you chose appropriate for this patient. So yes, we now have standardized it across all providers, at least in the wound care center. We all have the same standard when it comes to these three elements. So it's not and that was something too that took us a while to figure out because of making sure that you actually have this appropriate. Also, from a billing standpoint, you basically have to have these elements to get the full payment as well. So it took us a while to figure that out, but essentially, yes, we do follow that. And I did have to adjust it because I thought my notes were appropriate, and I think I could have passed an audit. I mean, I passed a couple of internal audits, but I thought my notes were strong enough to hold up, and some of them were, some of them were. So we had to go back and think about this implementation that was coming and make sure that we had all of that pretty much accommodated for. So pretty much not necessarily a true template, but you really can't go to the next step if you don't answer any of those other questions in our templates. So it's a little bit annoying. You get used to it. Now we're adjusted to it, so I don't really find it as annoying as I did in the past, but if it's like teaching an old dog new tricks. So if you were just saying, "Oh, I just want the CTP," and slapping it on, not explaining why for medical necessity purposes, you find it annoying. But you kind of have to explain that to the insurance or the payer, and then also understanding why you chose this particular CTP over another, given the stage and presentation of the patient's wound at the time, which we'll go over in some of my cases. But yeah, that is kind of became, I would say that became the standard for all of our wound care providers, both the NPs, the PAs, the DPMs, and the MDs that participate in CTP application.
Well, congratulations on that. I'm so excited that you did that. And now I'm going to be quiet and going to turn it over to you because since you've done all this work to select products with evidence, et cetera, why don't you tell us a little bit about the actual doing this in practicality?
Sounds good. I'll do it. You guys can see my screen? Just want to make sure we switched it over. You can see it, Miranda? I just want to, because I can't see it. I just want to make sure you guys can see it. You get, we're good? Oh, we're good? Okay. So this is my be like a mini, I'll call it case presentation more so than an actual lecture. So it's always fun. So I don't have to get into all the nitty-gritty sciences. So this is disclaimer here, just saying these are all my opinions, not companies I consult for. I am a consultant for LifeNet Health, who's having today's webinar. This is just my objectives. Won't really belabor that too much. And this is LifeNet's portfolio. Like I said, I really won't go too much into all of that just because it's more so educational. But this is this particular lecture, our presentation will focus more so on the clinical outpatient side, thinking of TheraSkin and Dermacell pores. So Dermacell pores is the human acellular dermal matrix here. So it's a dermal matrix. Really not much to explain there. It's non-sided, which I like, and it's also ready-to-use packaging. It's pretty much what I like to highlight. It's naturally porous. I always have to highlight that as well. And you can see there's various sizes, 3-year shelf life, and that's the HCPCS code there. You could just a little bit more anatomical. So it's intact dermal layer, endogenous growth factors, ECM as well for that. So it's a thicker product when you think of it. So because compared to most clinical products, I should say. So it's almost like a surgical product, except you get to use it in a clinical setting. But because Dermacell porous is thinner, it fully incorporates faster. So thinner than most OR products, thicker than most clinical products is what I'm referencing. Won't really belabor that too much. So it's the intact ECM here meant for chronic wounds. Really won't, like I said, won't really belabor it too much. This is endogenous growth factors and looking at the collagen ratios here as well for this product. Despite its thin profile, Dermacell is robust, so you can suture through it, which I like. You can skin staple it through. I even skin glue it for my clinical patients, depending on how compliant they are. Speaking of compliance, and it does have an intact basement membrane layer. Dermacell porous is non-sided, like I said, and it's a reticular only graft. So it's great incorporation. And TheraSkin will be the other product I talk about. So this is a dermal matrix as well. So this is a full split thickness dermal matrix graft here with living cells, retain endogenous factors, and then there also is a native ECM. But think of this one as like your split thickness autograft that you would harvest with a dermatome for your patients. Typically I would use this for patients that aren't great candidates for it, having a donor site graft application. It's particular also if they just are not healthy enough to go into surgery is another issue too. A lot of my patients are just too sick. This one does have 6 sizes and then a 5-year shelf life. This one is cryopreserved instead of being a shelf stable product. So, and it also is sided versus the Dermacell product. So TheraSkin is all human split thickness allograft. Like I said, I won't really go too much into the. So here's the cases here. Just kind of did that for didactic purposes before I just start talking about products and just start, like why am I using this product? So this is a gentleman, 64-year-old male, diabetic, diabetes type 2. It's almost like my typical diabetic patient comes in with a wound, luckily he had at the time his payer didn't have a grace period of coverage where I have to worry about the 30 days for graft application. And he actually had a chronic wound at that area. So I had already been treating the wound, but it actually got worse, became blistered. And I was like, oh, this looks much worse than previous presentation. So I did a debridement. Some of that gray tissue there is my silver nitrate because he was bleeding so much. Then we finally got a picture of it. So it looks like a lot of necrosis there, but there's actually a lot of it silver nitrate and lumicaine. So what I did was on this foot, did an in-office debridement. So this is here in the wound center, and I had talked to the prior authorization team. Like, oh yeah, he does. You should be fine to put a graft on him. But what I did was put a TheraSkin graft on him. So we have usually keep those preserved in our clinical practice in the freezer for the patients. So I actually skin stapled it on. So you can see there, this is the first, this is before I put the graft on, and then this is the next visit. End up putting a series of grafts on them, still skin stapling it on, and just showing a little time lapse of how the wound improved pretty much overnight. So they're going from not really overnight, but over a week. So you're going 822, 829, pretty much half a 50% reduction. Then going from 829 to September 19th, another 50% in reduction for this patient. And then going into the 1010 for this patient then applied another graft for the final closure for this patient. You can see there. So from August 22nd to October 10th of that year, patient reduced pretty much 80% in reduction with a series of graft applications. But this is for basically 4 graft applications for this patient. Then ended up going a 5th graft to close it. So that's him in April. So one thing I like about their skin is because it's human tissue and not xenograft tissue. Typically, when those tissues incorporate, especially the collagen replacement that occurs, usually the skin integrity is pretty good, and that's why I like it. So and it also. So when you're not just only closing a wound, but you're keeping the wound closed, and I like that. So it keeps that recidivism low, where it's low for these patients. So I like that particular. That's one of the reasons why I like a TheraSkin. So that was a TheraSkin. This case too will be another TheraSkin case. But I know we've harped a lot on the DFUs and the physician fee schedule, specifically discussing DFUs and also for these product coverages. But I like just for thinking of outside the box and for case presentations and getting more creative with CTPs, because I know a lot of people just think of diabetic foot, just slap it on the CTP. So this particular patient was actually going to be a candidate for a below knee amputation. I happened to be on call, and this is when I was on. So this is actually a surgical case too. So I was on call for the patient. I was on call for the hospital, and I get a call about this patient, and they're like, "Oh, we're about to, do a below the amputation. This patient says he had so much pain, he can barely do dressing changes. He needs Dilaudid every time he's getting changed." So what I did, did a chart review, looked at the time he wasn't diagnosed with diabetes, didn't have true peripheral neuropathy at the time. I mean, I've been treating him now. Now he has diabetes and he has some peripheral neuropathy symptoms, but we'll go to that later. So, go see him, work him up. And it's true, go do a dressing change. He's yelling, screaming. I have to call the nurse to get basically get a Dilaudid dose so I can change his dressing so I can actually assess what's going on. Then I look and I say, oh, these wounds are full of thickness, but there's not really like exposed tendon. Pretty much the subcutaneous tissues. I say if all you need is an OR debridement, we could do a TheraSkin graft application. So that's what we did. The main goal was really for pain control. Ideally it's great to heal these wounds, which is why I say, but I was thinking for also for pain control so you could actually tolerate dressing changes as I start thinking of getting them healed for wound care. So in that particular case, I ended up actually having 2 of the largest TheraSkins available to me, and I kind of went for the high yield spots for them. And so I essentially went to that distal area there, and then went to the more lateral aspect of his leg as well. Did some mixture of skin staple and skin glue for this gentleman, and you can see here on the more proximal layer, that's when I added the additional graft. So I did that in office. So all I had in OR was these 2 grafts, and then you can see the follow-up visit is after, and then I added another graft to the more proximal leg. And I really didn't add any more grafts after that. Just let them incorporate. I did try to keep them hydrated over time and just kind of let the body do its, incorporate and takes what it needed from it, the growth factors to heal and allow the wound to mature and turn into skin or epidermis. So here's another, start to remove some of the grafts that were becoming not necessarily necrotic, but almost pretty much the body was done with it. So I started removing some of those. You can see this is after one graft application for that gentleman. You can still see the proximal graft that I put on second in office procedure in the clinic. So he did well. So this is a time lapse of August 3rd to 10/10 of that year with the partial graft removal, still having that proximal graft intact there. And then March of that year, has a little hypergranulation tissue, but he pretty much healed that area. So going from August to March with one graft application, all I did was just put zero form on him. After that, I didn't even really do anything crazy. Just did petroleum impregnated gauze on him and let him do also did compression, of course, because never went back and put any more grafts on them for that particular case. So I like to highlight the power of their skin, especially when you think about painful patients. So this another cool case, was on call for this gentleman, did a neck fast case for him. So at that time, I wasn't really doing too many bare skins in the OR. So I was like, clean them up and I'll figure out what I'll do. Probably fill it in and then do a TheraSkin later. So that's exactly what I did. So it wasn't a true neck fast. It was more so a necrotizing infection, they called me. And I cleaned out that wound for that gentleman. And this is the OR surgical debridement. It was localized, wasn't a true neck fast, spreading proximally or anything. And this is the OR day. That night I did the OR debridement of the plantar foot. And you can see here the next day, clean area still looking great. So all I did was saline wet to dry dressings until I got them into the also because I don't trust them. And so I got him to my outpatient clinic and coordinated a TheraSkin application for this gentleman. Got that approved through his insurance. And this is after the first graft application. You can see there it started to granulate in there. So March 5th was the follow-up appointment. Then I put the graft on. So this is on the 12th after he's had that graft. You can see almost immediate granulation in between the 5th and the 12th for this gentleman. This is after the second graft application. So that same day after I did that, I put another graft on. This is after the fifth graft application going into May of that year. All the way up until August. Didn't do, I think, yeah. So I think after the fifth, I pretty much stopped because he always kind of disappeared on me and did his own thing. So he would just do collagen dressings and collagen dressing, calcium alginate dressings. Pretty much after two applications, didn't really need to use any more grafts for him. He did well up until August of that year. October of that year. This is time lapse there. And this is him in December, literally almost a year ago. So he's doing well. There it goes, January of this year. He did well. But this is another venous VLU. I like this case because it's pretty cool. So this case is highlighting dermacell pores. So gentleman I had healed before, actually healed him with TheraSkin before. Then he gets his wife decides, oh yeah, you finally don't have to do wound care anymore. What we'll do is we'll get you a puppy. So he gets a puppy, and the puppy reopened my same area after scratching him. So you can see in the past I had used Apigraph, EpiFix, and TheraSkin products to close that previous wound that now reopened. So this time I used Dermacell on the first application. You can see here, this is what it looked like. And first, so Dermacell on the first product that I used. And you can see here on the time lapse, that's just the dried Dermacell on the left. After you debride it, taking it off, you can see the granular wound there looking great. And then this is after another Dermacell application. He did well. So he ended up actually healing that wound and reopened again. But I just wanted to show the power of the Dermacell porous, especially in these VLU wounds, high exudative wounds, because the natural porousness of that graft allows for that egression of the drainage. So here goes back to not a true diabetic foot ulceration, but a neuropathic ulceration because he never actually had diabetes, but he has neuropathy, and luckily his payer was willing to pay for graft application for this. So this gentleman had a left plantar foot ulceration on the lateral aspect, almost going to the heel. But we had been using TheraSkin in the past. Actually, had almost gotten it closed. I should have showed those pictures in this when I present this case. But actually, did TheraSkin it for multiple applications. Almost was closed, and then one day he decides he wants to go on a road trip, go visit his family, and did a road trip, like a 10 to 12 hour road trip to Atlanta. And so of course he has his foot resting on the his left foot resting the entire time, and pretty much blew up my entire wound. So I was like, oh, you know what? I'll try, Dermacell porous, and so we did Dermacell porous because it was just so large. I needed something that could close it pretty quickly because he pretty much had a high risk foot. So I skin stapled that on that day. Well, once we got it approved and went through the approval process, got the graft and stapled it on for graft application. And you could see immediately starting to get granular and actually getting that reduction in size for this patient. So from December, might have did 2 to 3. I think I did 3 applications total for him. I spaced them out at that time. So December, and then this is him in May. Eventually, end up getting them closed. After didn't do any more graft applications after that. Just did wound care, regular collagen, calcium alginate for him. So just him in September end up closing. So it looked great. So going from December to September, 3 graft applications for a wound that he had this wound for 7 years. Most importantly, so I had met him because I did an amputation on his right foot, and then one day when I was consenting him to do the amputation on the right foot, he goes, "Well, I do," and he was like, "Oh, you never looked at the left foot." I was like, "You're right," because I was always focused on the right foot, and this is like the day of the surgery, and I look and he has this large wound there. So that's his case. So in closing thoughts, and then we'll get to some Q&A. Split thickness skin allografts are utilitarian. So thinking about it, using it for patients with pain, looking at diabetic foot, and looking at VLUs, and all these, both of these grafts products that have great evidence for these type of wounds and indications. Then infection must be treated and under control for successful outcomes. So not just slapping this in when just because I have it in the OR or just because I have it in the office. And it works great on large surface areas. So think about that. And then, of course, the better debridement you do, the better graft outcomes you get. So the more aggressive you get with the debridement, the better these grafts take. And not all wounds are candidates for these split thickness skin allografts. And of course, like Kathleen said, do your own research. Don't do it just because Dr. Johnson said it. And this 30-minute presentation. Otherwise, we'll do some Q&A and do some shared screen and talk to each other.
Thank you, Dr. Johnson and Kathleen, for those excellent presentations. The combination of reimbursement strategy and clinical application gives us exactly what we need to move forward confidently with these rule changes. We'll now have time for a few questions here up to the top of the hour. So if you have a question for Kathleen and or Dr. Johnson, please drop your question in the chat and we'll get through as many as time allows. And it looks like we've got quite a few questions coming in. So it looks like this first one is for you, Kathleen. What are the most critical documentation elements that physicians and qualified health providers need to support medical necessity for CTP application under the new payment structure?
Well, I could go on for an hour about that because all the components are important. All right. So I don't want you to just think that if I said it, it's the only thing you should be documenting. But some very key points is that you need to be sure you did the good, excellent standard of care. And if you did it and you document it, guess what? You may not need a CTP because wounds and ulcers do heal with good standard of care. So you should always document that. Now, if indeed we did not achieve with good standard of care the success and the outcome we want, then indeed you have to document the why. Why do I need this? And you must be able to refer to the documentation you've already done to show that the patient didn't have the outcome you wanted or just what happened. So the why do I need it? And then the why do I need that brand? I see that as a huge mistake that they just say, well, we put on a CTP. Well, why? Okay, and why that one? And that's what the evidence is for. And so we should refer to that evidence. And I think the other thing is the plan of care. There must be a plan of care. And that plan of care is extremely important because if you have to make any changes in the plan of care, you need to change it in your documentation so that you're always saying, this is what I plan to do, but I had to make a change, and now you change the plan of care. And then I think the other thing that I see that catches a lot of people in their audits is they don't really show very good progression with their measurements. There needs to be some way that you can literally track each wound by itself, one from the other. This is what's happening to wound one over X number of weeks. This is what's happening to wound two over X number of weeks. And it's important for you because it helps you to see your progress. It helps your staff to see, or any other physician who has to follow you, and it helps the payer. So those are the key things that I think, although there's about 40 items that need to be in your documentation, but that's the key points.
All right, another conversation for another day, right? Well, kind of
Yes.
going back to that, yes. So going back to the why piece, we have a question here for Dr. Johnson. So when you're selecting between products like Theraskin and Dermacell for a diabetic foot ulcer case, what are the key clinical factors that guide your decision? Like why are you choosing one over the other?
uh, I like the fact you said clinical factors because it's really payer clinical status because it depends on the payer really. If the payer is going to give me a coverage for a Dermacell or Theraskin, but we'll say hypothetically the payers say they're going to pay for both, and why did I choose those? It depends on the wound stage that wound is in. Typically, if in an ideal world, I would always like to go with a Dermacell porous first to at least get that wound more mature and then go kind of finish it off with a Theraskin. Sometimes the Dermacell will just finish it off, but it depends on what the stage of those wounds are. Like if you go back to that last case that I did with the neuropathic wound that wasn't true diabetic foot because he wasn't diagnosed with diabetes. But you saw at the end he had like this like hypergranular looking situation. That one I would go with more like a Theraskin because I would think going to a Dermacell porous would kind of be overkill because you may actually get up too much hypergranulation. Now you won't be able to close that wound. So that's the things that you'll learn as you kind of get used to the products because some of those products, yeah, you're like, oh, I want granulation. You may get too much granulation tissue. So it depends on the stage and of the wound and then also the size. There is a size limitation with the porous, though I hear they may be coming out with larger sizes. Their skin comes in larger sizes. So if I would have just, and then so also I'm thinking about cost, like what if I use that like Dermacell for that one VLU situation where it was going from proximal to distal to the leg, that would cost me way more money putting all of that Dermacell on there versus using a Theraskin that's more cost effective product. So that goes back to Kathleen, like the why. It's like, why did I do this? And I dictate that in my notes, like why I chose that so I can get more spread, so I can get it. And obviously, yeah, I could have probably healed it quicker with the Dermacell porous or something like that, but I go with a product that's more advantageous for the patient and things like that. So that's the real thought process. But yeah, you kind of realize, what stage that wound's at and how large it is and if it's been reducing in size. Because I've already been doing standard of care. Most of these, it wasn't like I wasn't doing standard of care on these patients. So if I already got it and I'm on the train trying to get them healed, I'm like, oh, this wound's really maturing. I really just want to close it up for them and let's see if the payer will pay for it. So submit a prior authorization and get that approved and kind of do it. Most times I'm not doing that the first visit we just met. Even if it's a patient that's second, third opinion, I try to avoid that unless they kind of already know, and then we have that conversation.
Mm-hmm. Right. So it's process within a process. Sounds
Yeah,
like.
and
Yeah.
yeah, it's almost like I feel like I always tell my patients I'm a chef because even they don't really understand like why is Justin switching it over and it's because I'm trying to get certain things going with the wound. Sometimes
Right.
I'll just
Yeah.
I'll stop an application if it starts to improve and let it do its thing. They say like even for these cases, it was just I was most of those I think all those cases the highest I got to was 5 applications.
Hmm. Right. Right. Interesting. Well, thank you for sharing that with us. Now we have a how question. So we just talked about some why. Let's talk about some how. So, Kathleen, how should practices approach conversations with payers about coverage for CTPs, particularly for Medicare Advantage plans that may interpret the MPFS changes differently? Kind of an interesting question to ponder, huh?
Good
Well,
question.
this presentation is about payment. So let's
Mhm.
remind that, okay? We don't yet have the
LCD.
final coverage rules for Medicare. All right. There are three MACs that do have published LCDs, but the question is about Medicare Advantage. Now, the Medicare Physician Fee Schedule doesn't apply to Medicare Advantage. It doesn't apply. All right. Your contract with the Medicare Advantage payers is what you have to work on. So, this 127 doesn't mean anything to a Medicare Advantage payer, all right? Because they right now our professionals and our outpatient departments have contracts with these Medicare Advantage programs, and they're going to pay what they're contracted to pay. So if indeed you don't like the payment rate, then you need to start thinking about that a year or so before your contract is up so that you can negotiate with the payer and show them your outcomes and show them why something needs to be have a higher payment, etc. So what goes on with the Medicare Advantage payment and coverage does not connect to this payment program that we just talked about. So I don't want to give anybody the false impression that Medicare Advantage has to pay 127.28 per square centimeter. That's not true. Okay? It's all about what's in your contract. And surprising to me, whenever I talk to a lot of professionals, even and particularly the outpatient departments, they don't even know what their contracts say. All right. So they could be complaining about, oh, we don't get this or they don't cover that, whatever. But when you look at their contract, that's what their contract says I should do. So everybody needs for Medicare Advantage, my biggest thing to you is go get those contracts and read those contracts and find out when do they come due for the next negotiation. And if it's 2 years from now, you have to start now to start to collect your data and start to talk with them about it. It's a total
Mhm.
different thing than the straight Medicare program.
Well, thank you for that guidance. I think we have time for one more question, and I'm going to throw this one at you, Dr. Johnson, given the nature of the question. How do you counsel patients about CTP therapy, particularly regarding expectations for healing timelines and the number of applications that may be needed?
Yeah, so that goes back to the evidence base. So, I mean, I wouldn't. I mean, if they want me to bring a scientific paper, I will. But most times, I explain to them the clinical evidence in the peer-reviewed literature that's out. Not even necessarily what's on the brochures or something like that. We're talking about, the RCTs that these companies have, and that goes back to Kathleen's, questions about the evidence-based products. So it's almost like, yeah, that's a great question. So yeah, it's like those are all evidence-based products. So now I feel comfortable talking about these products with these patients and letting them know, like, oh yeah, on average, you may get 7 or 8 applications. And sometimes it goes to like where I explain to them, I like to spread them out because of the payer says, I only get to put on X amount of, usually it's about 10, right? They only want me to put on 10. But also now they, depending on what the LCD situation, which that's different this conversation, yeah, may I only have 12 weeks to put them on. But I also have to think about things like that of the time frame. And all this upfront conversation. So most of my patients aren't necessarily surprised. Maybe if they're not fully healed or where they want to be, they act like we didn't have this
Mhm.
conversation. But all of that is in there and is documented that, just, it's not, I don't do a whole 2 paragraphs, but it's maybe 2 or 3 sentences, explain to the patient treatment plan and the process. That goes back to the treatment plan that Kathleen alluded to as well. So that's all treatment plan conversations. So that's kind of how you do it. And you let them know that, this is not a silver bullet. These are products that help patients that do, still do their offloading, still eating nutritious food, still managing their glucose, and still following with their, other providers, and still, making sure if they're being treated for chronic osteo, still making sure they're going to their infusion and making sure they're taking their oral antibiotics. So this is all, a group thing. The CTP is just, one piece of the puzzle. It's not going to be the entire puzzle for this patient to heal them. So, and usually that's a conversation we have before we even start. And I consent my patients to even pod these graphs. So all of that's discussed in there.
Well, thank you, Dr. Johnson. I wish we had a whole nother hour because there's more questions to get to, but we'll try to handle those offline. We're at the top of the hour, so this wraps up tonight's Learning Live session on CTP strategies for 2026, sponsored by LifeNet Health Biologics. A very sincere thank you to Kathleen Schaum and Dr. Elton Johnson for sharing their expertise and joining us for today's Learning Live. The combination of reimbursement, insight, and clinical application you provided is so invaluable as we all navigate these upcoming changes. And I want to thank all of you in the audience for being a part of tonight's session. Your engagement in the chat has been wonderful, and your questions demonstrated exactly why this topic matters so much to our frontline clinicians. I'd also like to extend a very warm thank you to LifeNet Health for supporting today's education. Now, before we go, if you found this valuable, please like this video, share it with your colleagues, and follow us on your platform of choice, whether that's YouTube, LinkedIn, or Facebook, so that you don't miss a future Learning Live session. And if you want to dive deeper into any of these topics, including DFU management, CTPs, payment policies, be sure to visit Wound Care Today USA at wct-us.com for additional educational resources. This concludes this evening's session. Thank you all and have a great rest of the day.